morning and welcome to Surgery Grand Rounds. There is no commercial support for today's program. The speaker and planners have disclosed no relevant financial relationships with commercial interests. If you have a question for the presenter, please hold until the Q&A segment at the end of the talk. If you are attending virtually, you may enter your question into the chat. A link to the event survey will be shared at the end of the program. If you are ABS certified and want NGHS to report your CME credits to ABS, please fill out the evaluation and give us permission to do so. And now it is my pleasure to introduce our guest speaker. A Colorado native, Dr. Anderson received his undergraduate degree from the University of Nebraska at Omaha, graduating magna cum laude in biology with a minor in chemistry. Prior to his undergraduate and medical school training, Dr. Anderson served in the U.S. Navy for 6 years as a helicopter search and rescue swimmer. Dr. Anderson graduated Ross University School of Medicine with highest honors. During medical school, he was actively involved in peer tutoring and served as an anatomy and neuroanatomy teaching assistant. A member of the American College of Surgeons and the American Medical Association, Dr. Anderson will be going into a vascular surgery fellowship at the University of Nebraska. Outside of the hospital, his hobbies include spending time with his wife and 2 kids, enjoying hiking, fishing, bowling, and arcade games. Please join me in welcoming Dr. Ryan Anderson.
All right, thanks everyone for coming. I'd like to start off and say, if anybody makes fun of me, you get an extra 24-hour call. So that's how we're going to start all this out. All right, so obviously going into vascular fellowship, so I thought for my grand rounds, I'm going to do something that's vascular related because that's what I'm interested in. So I'm going to talk about carotid endarterectomy, and it's going to be versus the carotid artery stenting. So what really are these procedures? Why would we do them? And when would we choose one over the other? And I don't have any disclosures yet. They're going to come someday. And a whole bunch of stuff we're going to talk about. It shouldn't be too painful, but I'm going to go over the history of the carotid endarterectomy, what's the epidemiology of the disease, the different techniques of the endarterectomy, potential nerve injuries, which is really important, especially for residents when you get into these cases. Describing different carotid artery stenting procedures, the indications for artery revascularization, and then of course the different various neurological modalities that you monitor the patient during the surgery itself. So just to get everybody a little history on the carotid endarterectomy. So this physician here, back in 1951, he was a neurosurgeon out of Buenos Aires, Dr. Raul Carra. He initially, this is the image of what he did, which was much, much different than what we do now. But he actually resected the diseased portion of the internal carotid, as you can see on the left side of that picture there. And then he anastomosed that to the external carotid, which is, again, drastically different from what we do now. In the papers, it records that he had no issues with this patient up to 39 months. So not really sure what happened at the 40-month mark, but at least 39 months were good. Everybody should, if you don't recognize this picture, should recognize this name. This is Dr. Michael DeBakey. He was a general and cardiovascular surgeon. He claimed that his was first completed in 1953 and that he was one of the first ones here in America that did it. However, he didn't report it until 1975. His reasoning for that is that he stated that he doesn't like to publish things right away. He wants to collect sufficient data before printing. So 19 years later, hopefully he had sufficient data. But I think a lot of the reason that he jumped out saying that he was the one that completed this earlier in 1953 is because, actually, before I do that, this is what he did. This is very similar to what we do now, with the exception of doing a patch angioplasty, but he actually make an anterior arteriotomy, and he would clean out the vessel, and then he did a primary repair of that one. So Dr. Denton Cooley, this is one of the reasons that he kind of jumped in and said, no, I did mine back in 1953, because Dr. Denton Cooley did his in 1956 with the assistance of Dr. DeBakey. What's interesting about him is his patient that he did really had no neurological symptoms. This patient came in saying that he just had some swishing in his ear, which is something that you can see when you see your patients in the ED and they have some swishing in the ear. You start thinking about carotid stenosis. But during his surgery, he wanted to decrease the neurological deficit somebody may overcome, and he actually immersed their patient's head in crushed ice while he was doing the surgery. His was very interesting as well, too. So he did basically clamping technique like we do now. And he did shunt, which is what you can see, that polyvinyl shunt that's right there, but it has 2 needles on either side. And so he'd go on either side of the clips just so he can shunt the blood to decrease any neurological deficit. But if you can see shoving a needle in somewhere like that, you're going to decrease, or you're going to increase the risk of plaque disruption and increase the risk of stroke. So his patients afterward, after surgery, was aphasic, had a right hemiparesis, reportedly was okay, getting better after the first month, and then after 6 months was back to their normal self. So there was a randomized control trials that was done in 1969. It showed that surgery itself reduced the incidence of stroke in symptomatic patients. However, there were some higher complication rates afterwards, and it made it difficult to continue with the surgery itself. But as techniques got better, science got better, medical technology got better, they did some more trials in the 1990s, and they were able to definitively establish the safety and efficacy of the surgery. And they showed superiority over best medical management, which is something I'll be going over later throughout these slides, in patients that both had symptomatic and asymptomatic disease. All right, so a little bit on the disease itself. Up to 750,000 people have strokes annually in the United States that's reported, which is pretty significant. 15% of these are fatal, 15 to 20% severely disabling, while 15 to 20% of strokes who recover, they experience subsequent strokes afterwards. At least 80% of these strokes are ischemic, and what brings us into doing surgery on our side for the carotids is the atherosclerosis of that cervical carotid artery is responsible for up to 20% of these ischemic strokes, which again is pretty significant. All right, so we'll start getting into some of the fun stuff. So the conventional carotid endarterectomy, there's 2 different ways you can get in. You have your standard longitudinal incision, and you have a transverse incision. Longitudinal will be on the left, transverse on the right. Both of these, it's going to be mostly surgeon dependent, what they trained with, what they end up liking. Some of them, the transverse on that right, you can get into a neck crease. It helps with scar. You basically don't see the scar very well. Downside to it, though, is if you get in and you end up having a very high lesion, it's going to make it difficult to get up to that area. Or if it's a very proximal lesion near the clavicle, it's going to make it difficult. The longitudinal, you're going to go along you're going to parallel the median border of the sternocleidomastoid, and you can essentially extend that excision either way, whichever or however much you need, but it is going to have a larger scar in the end. All right, so surgery itself. This is the conventional carotid endarterectomy. This is obviously a very brief description of the surgery itself. I'm not going to go into a lot of detail on it, but we'll still touch on what the surgery itself is. So make the incision either way, whatever way has been trained, whatever way you like. You fully expose your vessel. Once this has been done, this is key. You're going to give 80 units per kilo of heparin. Allow this to circulate in the body for 3 minutes. And this time, we're going to clamp. The clamping is important, especially for residents when you're taking abscite and they ask you questions like this, or you're being pimped in the OR by the attending. You're going to clamp using the mnemonic ICE. So you're going to go internal carotid artery first, followed by your common carotid artery, and then the external artery. The whole purpose of this is that you clamp that internal first, so if you do disrupt any plaque or debris or anything, you're not going to shoot it straight up into the brain and cause a stroke. And then you're going to clamp the common then, and so if you do, again, disrupt anything, it's going to go through the external, which is not going to cause a stroke. It's going to go towards the face, but it's not going to cause them any long-term deficits. At this time, once everything's clamped, you can create your arteriotomy along the anterior wall of the vessel, and you're going to mobilize the plaque and remove. Again, this sounds very simplistic. It is much more into that than I'm showing right now. Once the surgery is done, you're going to repair, or at least the endarterectomy is complete, you're going to repair the arteriotomy with a patch angioplasty. There's multiple different things you can use. You can use PTFE, you can use Dacron as your synthetic side. A lot of places use bovine pericardium as one of the best that are used. At the end of the case, which once everything is done, you're going to release, and this is again something that's important. You have your ice mnemonic to be able to clamp on. You're going to do the reverse of that to take the clamps off, and it's for the same thing. The whole reason is that if there is any disruption of any plaque or anything like that, we're going to shoot it through the external rather than into the brain through the internal carotid. So you're going to release that external, followed by the common, followed by the internal carotid. So another interesting version of the carotid endarterectomy is an eversion endarterectomy. This one looks much different, as you can see. The beginning stages are the same. You're still going to expose your vessel. You're still going to give your heparin. You're still going to clamp in the same order in which you clamped before. But in this one, we're going to completely transect the internal carotid artery right at the bifurcation. And then, as you can see in B here, over here, they're going to actually circumferentially pull the adventitia off of the plaque. You're going to try to go as distal as you can, and you're going to transect the plaque at that point. As you can probably see, once you transect a plaque, you take some scissors and you cut it off, there's going to be some endpoints on that. So you can't just let that go. You're going to have to tack that down. So that's another added difficulty in this procedure is you're going to have to make sure you tack down those plaques. You don't want to have an abrupt wall to where as soon as you release all your clamps, the blood coming from the heart is going to push up on that wall and it's going to chip off a piece of plaque and you're going to have a stroke. So once all that's done, you're going to perform your end-to-end anastomosis, and again, you're going to release the clamps just as you would have in the conventional carotid. This was initially first described by Dr. DeBakey that we saw in the first couple slides. When he did his, it was slightly different. He transected only the anterior portion of that near the carotid bifurcation. Following him was a surgeon named Dr. Etheridge. He revised DeBakey's technique, and he did what's actually in this cartoon here, where he transected the entire internal carotid at the bifurcation. All right, so which one of these is better, doing the conventional or the eversion? So a lot of this stuff is going to be up to wherever you were trained. It's going to be up to the patient's anatomy, stuff like that. So the eversion technique has a lower incidence of stenosis, which is reported in literature. There is no patch needed, as you can see. There's just an anastomosis at the bifurcation. The eversion is more effective, and this is where it kind of comes into play. If you have a really redundant coiled or kinked ICA, this can help out. It can make it a little bit easier than doing your arteriotomy on something that is redundant and making it more difficult. However, there is more more extensive dissection that's needed with the eversion technique. It's difficult to shunt with the eversion, however, not impossible. And then, as I was alluding to earlier, that it's difficult to visualize the endpoint of that plaque with the eversion. So you're going to make sure that you have to tack that down, which can be challenging in itself too. All right, and so with this presentation, there's been a lot of studies dealing with carotid endarterectomy, carotid artery stenting. There's a lot of studies that go with it too. So unfortunately, we're going to have to talk quite a bit on these studies. This particular one was the Everest trial. It was a large Italian randomized controlled trial that was prospective, multi-center, had around 1,400 patients that were involved in it. And the whole point of this was to see, do we do eversion, do we do our conventional? So they found that there were no statistically significant differences in the techniques. There were slightly higher incidents of having perioperative complications with eversion. In particular, they recorded 8 deaths, 6 of which were in the eversion group, 2 were in the conventional group. In that eversion group, the ones that did die, 3 of them were involved in ischemic stroke, 1 died of a hemorrhagic stroke, and 2 of an MI. In the conventional population, it was 2 patients that died of cardiopulmonary arrest. They did show too that there was a slightly higher incidence of restenosis with the conventional group, which is something I spoke about earlier, 2.5% versus the 5.2%. However, this again was not significant. All right, so getting into surgery itself too, really important nerves. This is obviously, this can be a big deal. You can cause a lot of injury to patients if you're not being cognizant of where these nerves are, what they do, what happens if you injure these. So this diagram shows it really well. So cranial nerve number 10 being our vagus, we have our hypoglossal cranial 12 here, and we have our glossopharyngeal cranial 9 here. Your marginal mandibular is going to live up in this area, and I'll have another little picture that helps us show that one. So what happens if we injure these nerves? The hypoglossal, this particular patient, if they had surgery, would have had it on this left side because it affects the ipsilateral tongue, causes weakness and atrophy, difficulty swallowing. You know, of course, you get this tongue deviation to the ipsilateral side. Going back into the vagus here. Injuring the vagus is going to be similar to if you were to injure the recurrent laryngeal nerve and say if you were doing a thyroid surgery. And so with this, though, it leaves the patient developing hoarseness, difficulty swallowing, they're having aspiration risk. It leaves the vocal cord abducted on that particular side, as you can see here in the picture. Next one, glossopharyngeal. This one is a pretty significant one. It's difficult to get to this nerve. It is very high up. The one you worry about getting to this one is if you really have a high lesion, and as you start progressing, the posterior belly of the digastric muscle is going to be living over this area. Excuse me. It's going to be living over this area. So when you divide that posterior belly, you're at an increased risk of injuring this nerve, which again can be pretty significant if you do. Causes difficulty swallowing, gag. Sorry. How should you divide it? No, I wouldn't do anything like that because you do have nerves in that area. So I would tie them off and scissors in between. it's a good point too. Obviously, you don't want to do any type of bovine or any type of nerves, just as any other surgery you do. That's the last thing you want to get in that area. You're going to cause an injury to the nerve just from the heat alone. So again, with glossopharyngeal, difficulty swallowing, gag reflex is lost, aspiration risk, just it's going to be pretty severe, and it may affect the parotid gland function as well. And the marginal mandibular, again, here's another picture that's going to show a better area of where that is. You can see the yellow nerve here on top. A lot of this with the marginal mandibular is going to be from retraction. Patient's going to go into the PACU, you're done with surgery, nurse is going to call you and say, I think the patient's having a stroke. Their lip is starting to droop. So you're going to go and evaluate your patient just as you would anyone. You're going to do your workup to make sure they're not actually having a stroke. And what you see here is this lady that's sitting right here, and she has this drooping of this left lower lip. This is what you're going to see with the marginal mandibular injury. You have the ipsilateral lip paralysis and that drooping of the corner. So with all these with these nerves in play and with doing surgery, the incidence of cranial nerve injury from a CEA can be, it's a wide range. They range 2 to 50%. Most of these injuries, however, are transient. It's not due to basically a transection of the vessel, but more of just, it could be maybe, or you have the bovie in the area like we were just alluding to, or is it a traction injury? So a lot of them develop neuropraxia that's just because of that retraction. All right, we talked quite a bit, a lot of stuff right now, so kind of a little brain break. I like to think of this first one here as just being in residency. And the last one, I think I've said a couple times myself, why was I even born? So a lot of it can be pretty stressful. All right, so going over carotid endarterectomy, now we'll get into carotid artery stenting. Two different carotid artery stenting that we can do. This first one I'm going to touch on was the transfemoral carotid stent. A lot of these patients must have a high diagnosis of high-grade stenosis, be symptomatic or have a high risk of CEA. However, there has been patients that have done it with asymptomatic. When you're doing stenting versus the CEA, these are the ones where patients who have had radiation to their neck, they have severe comorbidities, a lot of cardiovascular issues, pulmonary issues. They're not going to be tolerating the big open surgery like that. They've already had carotid endarterectomy on that side, a lot of scar tissue in place. You can start considering doing stenting. So initially, they thought that being elderly was the main indication. However, data showed that there was a risk of adverse effects that were actually higher in the elderly patients. So a lot of data says that if they're older than the age of 70, you'd actually prefer to do an open, doing the carotid endarterectomy, just due to the data. All right, so what is this data? So there was the SPACE trial. This trial itself was proven whether or not carotid artery stenosis was not inferior to a CEA. Long story short, it did not prove it. But it was a multinational prospective randomized control trial, and they took in patients from March of 2001 to February of 2006. Again, their whole purpose of doing this test was to, their hypothesis was that carotid artery stenting, it was not inferior to the endarterectomy for treating patients that had severe symptomatic stenosis. They did a 30-day benchmark and as well as a 2-year, and they were not able to show a non-inferiority of that. They showed recurrent stenosis of greater than 70% was more frequent in the stenosis, or excuse me, the stenting group at 10.7 versus 4.6, and that was significant. This is a pretty big trial. This is a landmark trial for carotid endarterectomies. It was randomized controlled trial, had roughly 2,500 patients in it, and the whole purpose was to see stenting versus doing a carotid endarterectomy. They found symptomatic and asymptomatic patients that were randomized to either the stenting arm or the endarterectomy arm, and after a 4-year follow-up, they found that stroke was going to be higher in your stenting phase versus your carotid endarterectomy at 4.1 versus 2.3%. However, on the flip side, there was a higher risk of MI in your endarterectomy group at 2.3 versus the 1.1%. And they are currently in a CREST-2 trial right now. It was just this last summer they had apparently completed the recruitment of all their participants. And the whole point of doing that one now is that we're going to compare best medical therapy alone versus having a best medical therapy with stenting, and then the other arm is going to be best medical therapy with endarterectomy. So best medical therapy now is drastically different than when this first came out. The study was in the 80s. It came out, and best medical therapy was really just putting the patient on aspirin. So drastically different what it is now, and that's something I'll go into later so everybody knows. All right, so the other stenting that I was talking about, this one's going to be TCAR. This is a transcarotid artery revascularization. It's been out 5-10 years now. We're doing it quite a bit at this hospital now as well too. Most of the existing guidelines that were published prior to TCAR rule was really not yet defined. There's still waiting on a big study, randomized controlled trial for the TCAR itself. As you can see, it's a little bit different in here. So we touched previously on the transfemoral, and basically when they do the procedure, and I didn't go into detail on this one, but you have to try to decrease the amount of plaque that's going to be disrupted as you're sending a wire in that area. You don't want to obviously have that sent into the brain and cause a stroke. And so they release essentially a little basket that's going to be distal to the area that's working. It looks like a little umbrella that's going to be collecting the debris. This thing here is a little bit different. It's called a flow reversal system. And what they're going to do is basically when you get your access, you're going to go into the common carotid. They're going to put they're going to enter the common carotid here, and then they're going to have access to a femoral vein. And it's a passive flow reversal system. Basically just uses physics. Blood's going to go from a high area to a low area. Obviously, you're coming from your carotid, which is going to have a high pressure system versus that low pressure. And what it does is basically, just lack of better terms, it's going to suck all that plaque out from that area, and it's going to shove it into the venous side. They did a trial on this one just to see how good is this flow reversal system, which is the Roadster trial. The whole purpose of it, again, was to check the safety and efficacy of that study for reversal of flow and how well it actually did. It was a prospective single-arm, multi-center trial, and they did show that it was safe and effective at preventing stroke. And their rate of 1.4% was actually the lowest reported to date for any prospective multi-center clinical trial that involved carotid artery stenting. All right, so we talked about a little bit about what the indications were for a carotid endarterectomy, but to be more specific, things are these, when residents are doing abscess, these are the things that are going to pop up on whether or not you would do this procedure. So indications, symptomatic patients having 50 to 99% ICA stenosis. And again, we say 99, you're not going to do surgery on somebody who has 100% total occlusion. Basically they've been living with this one. If you were to go in there and you were able to get that plaque out, now you're putting in a bunch of blood into an area that had a decreased blood supply to begin with. So you're basically, the risk of causing further injury is higher than if you would actually go in. So that's why they give a 99%. With the asymptomatic patients, it's with 70 to 99%. And that's with the caveat of having a 3 to 5 year life expectancy afterwards. There were some places, I think even around the world now, where they don't operate on asymptomatic patients. The most appropriate first test to order would be a duplex ultrasound. So you have your, which you can see on these top images here. I don't know how well you can see it from where you're sitting, but there is a little bit of plaque debris here, which is actually narrowing this internal carotid artery here. And on this bottom here, this is going to be a CTA. Again, left internal carotid here, you can see all this white here is plaque, which is significantly narrowing the vessel. So once you've gotten your ultrasound, you can see that there is stenosis in that area. You can order a CTA. The CTA, it'd be good to do before the surgery anyways, because you can see how proximal or distal your lesion is. The CTA or MRA, if you're suspected, obviously. And then there is evidence, though, that the CTA itself underestimates how much stenosis you have. The MRA is going to overestimate. So if you come in with your ultrasound and it tells you that it's an 80% stenosis, don't be alarmed if your CTA or MRI is going to say otherwise. All right, some more trials. So we have the NASCET trial, a pretty large trial that investigated both high and moderate grade stenosis. And the purpose was to randomize patients to just doing this best medical therapy versus doing carotid endarterectomy and medical management with the best medical therapy. Which one was going to be better? Do we leave them alone? We just give them medications, or do we actually operate? So at a 2-year follow-up, they showed that there was a significant reduction in the ipsilateral stroke. And these were on patients that were just the high-grade stenosis at this point. And the 26% of them are the ones that had both the carotid endarterectomy with medical management versus the 9% that had, excuse me, I said that backwards. So 26% that just had the best medical therapy and 9% versus the best medical therapy with surgery. And then for the moderate stenosis group, it wasn't as significant. It actually showed after a 5-year follow-up that the ipsilateral stroke in just the carotid endarterectomy was 16.7% versus the 22.2% in best medical management with that. And more trials. So this particular trials, these are the ones where we're looking at asymptomatic disease. So the CAS trial, prospective multi-center randomized controlled trial, it involved patients have asymptomatic stenosis recorded of greater than 60%. At a 5-year follow-up, they showed that stroke and death rates 5.1% in the endarterectomy group versus 11% in your medical management group. So it was pretty significant on that side. The ACST1 trial was a randomized controlled trial. It was multi-center as well. This one compared doing an immediate CEA to a deferred CEA in the asymptomatic patients. Deferred meaning that they would wait until patients essentially became symptomatic. The whole goal was to assess the effect of the immediate CEA on stroke risk compared to the deferred. And the results showed that it immediately reduced, the immediate endarterectomy reduced a 10-year risk of stroke without significantly increasing the perioperative mortality and morbidity. So it was pretty significant as well. All right, so what is best medical management? What is best medical therapy to date? Now that we have all the medications, we have all the advances in medicine, smoking cessation is pretty obvious. Blood pressure control, we want to make sure they're on a high-dose statin, make sure we're controlling our diabetes, whether or not they're on aspirin or Plavix and or both. These are going to be our best medical management. So anytime you have any of these, if you get asked a question about what it is, what is best medical therapy, these are what you want to be answering. All right, and finally, we talked about neuromonitoring initially, multiple different avenues that you can do neuromonitoring. I think a lot of this is going to depend on how the vascular surgeon was trained, where they were trained, how they particularly did their neuromonitoring. That from my experience right now. So you can do stump pressures. Stump pressure is the ICA is going to be clamped. They're going to put in a small butterfly needle that's going to be distal to that clamp. And what they're doing is they're measuring the pressure from the contralateral side via the circle of Willis. So the pressure range is pretty wide, 25 to 70 millimeters of mercury, but it's stated that if you have a pressure of less than 50 millimeters of mercury, that pressure from that contralateral side is not going to be great enough, and that they're at an increased risk of a neurological deficit after surgery. So it would state that you would want to shunt at that point. A lot of people do stump pressures alone. They'll do stump pressures with EEG as well too. So EEG I know is something that we use at this facility, and you'll have an EEG tech that's sitting in the room, have the patient all wired up, and once you go to clamp your vessels, they're going to see if there's any discrepancy in the EEG. If there is, at that point, that's where you would want to unclamp because you know there's an increased risk of causing a neurodeficit, and they would shunt at that point. There is a somatosensory evoked potential monitoring. This one's pretty interesting. It's basically you're doing everything like you would normal, setting everything up, and they're going to do a peripheral evoked potential on a nerve. A lot of time it's going to be the median nerve is one that they can use, and if they show after you clamp, there's a 50% decrease in the amplitude that is used as a marker of ischemia, stating that you need to shunt for this patient. Transcranial Doppler, haven't seen this one used. It was introduced back in the 80s. Initial findings thought that having a normal transcranial Doppler, you could avoid shunting by a third of the patients. However, with having an abnormal transcranial Doppler, it predicted ischemia by EEG criteria only 60% of the time. So, it really isn't that great. If you're really paying attention and you're doing this, you can actually see some microemboli intraoperatively if they start passing by, just because it's an ultrasound going over the vessels. Recent studies reported that the transcranial Doppler and stump pressures were not very accurate in predicting cerebral ischemia. And then probably one of the best neuromonitoring you can do is an awake carotid endarterectomy, which sounds terrifying, but the patients will be getting a local anesthetic to keep them comfortable during the surgery. They're going to have a ball or toy or something like that in their hand. They're going to clamp the vessels, and at that point, you're going to ask them to do those things. You're going to ask them to squeeze the ball, see if there's any type of neurodeficits. Again, if you see anything like that, any neurodeficits, that's the point where you're going to want to shunt. All right. These are all of my references, quite a bit on there. I'll take any questions.
I want to explain TCAR in the baby terms. I looked up about 3 times, and every time I go back and look it up, I still don't know. So explain TCAR to all of us who don't know.
Sure. So you're basically going to be putting in a stent via the neck. And so you're going to make an incision how you would do a normal carotid endarterectomy. You can make either a transverse or you can make a longitudinal incision. You're not going to necessarily want to expose the entire vessel itself. You're going to be putting you're going to put wires, you're going to put needles in there, and you're basically making the vessel more mobile at that point. So you're going to expose a portion of the distal common carotid. say you want to have almost like a landing zone about 5 centimeters from your clavicle. This gives you an area to be able to do the procedure as well as having that reversal of flow in place. And at that point, once you get the reversal of flow, you're going to put a purse string around the common carotid. You're going to get your reversal of flow in. You're going to clamp distal to that, and that allows the reversal of flow to really kick into gear because you're going to have that pressure coming from the contralateral side, and it sends all of that plaque and debris through that reversal of flow down into the femoral vein side. And then at that point, it's basically just putting in a stent from basically being outside the body without having to make an incision into the vessel.
Thank you for the presentation. I've always been an admirer of the entire vascular surgery field, specifically because I envy the number of trials that we've been able to run, study, dissect every procedure that we do, and come up with answers for questions. I would love some advice on why I haven't been able to do it in my field. Is it just the number of patients? Is it just because I treat rarer disease? Or is there something else that the whole vascular surgery team across the country and the world is doing that us as in surgical oncology and hepatobiliary are not? Would love some opinion on that, please.
That's a good question. I can't allude to why an HPB surgeon would necessarily do it. I know neurosurgery, there are some places still where neurosurgery will do the carotid endarterectomies. However, honestly, unless Dr. Rideout has a specific on that one, I can't really allude to why anybody other than vascular neurosurgery would be doing the procedure.
Forgive me, you may have misunderstood my question. What is it about the vascular surgery field that makes you so good at running these trials? And why aren't other specialties able to replicate it so well?
Oh, just because of the trials themselves?
Mm-hmm.
Okay. I think a lot of that too is just based off of the number. I mean, in America, I think this is kind of a haven for vascular surgery to be able to be performed. So smoking, just diet alone, and the amount of patients that have plaque buildup, and you can see that we have 750,000 patients that are having strokes every year. Granted, they're not all from carotid disease, about 20% of that. But I think just given the number that we have, we're able to make advancements and be able to do the study themselves.
Yeah, one thing that vascular surgery does pretty well is it's kind of a smaller, close-knit community. There's not a large number, and they actually track data very well. So, there's several. The Society of Vascular Surgery does a good job of trying to kind of constantly. And this is what when I was graduating fellowship, one of the guys told me. He said, you got to constantly track your outcomes and your data. So, you don't want to make rash decisions, and, good piece of advice I got. You don't want to make rash decisions on, you do 100 carotids and one of them goes bad, and, and then you totally change everything. And that's kind of the mentality is like, man, what happened? I need to totally change my practice. But vascular does a good job because they follow stuff over time. They're constantly collecting data. They're constantly trying to reinvent and make sure they're doing the right thing. And the data collection with the VQI, the Vascular Quality Initiative, is a big deal. The SVS has, they look at NISQIP data closely and things. So they're constantly looking at stuff. And just because there's not a whole lot of them, several thousand in the country versus, general surgery and, hepatobiliary and surgical oncology, the numbers are just much greater. That the meetings wise, when you go, you'll see the same people there, repeatedly from all over the country. And they're constantly kind of talking about, new techniques or what they do, and they're constantly presenting new data, and they're always kind of reinventing stuff. And a lot of it, is territorial kind of stuff, to be honest with you. I mean, with IR and cardiology with the carotid stenting, then they kind of reinvent it and say, hey, how can we keep this with us? And it involves making an incision in the neck, which they can't do. And then all of a sudden now the data's better and you can kind of keep it. And so, there was a huge argument about a year ago because they were before, the FDA, and trying to say that transfemoral stenting was equivalent to, carotid endarterectomy as well as, TCAR, and that's just not true. And so they were trying to look at expanding carotid artery or transfemoral carotid artery stenting, for having a wider indication, and that kind of got shut down pretty quick. So they do a good job of constantly reevaluating stuff, and that's what you should do all the time. If you're have the same complication over and over again, or you're looking at data and you're doing the same procedure, always trying to look at how you can make it, the best and the safest for sure.
Do we have any other questions? Oh, we have one, okay.
Back. Oh, careful what you.
That's an extra 24-hour call.
Why do we not have like cerebral monitoring for TCARs?
Yeah, you can. I mean, you can do it. I think it's so quick and the stroke incidence is so low. But some people will do it. Yeah.
Because what I was thinking is you have flow reversal, so you're actively pulling blood out of your like cerebral circulation, so they should have higher chance of ischemia, and if you're going to do lithotripsy at that time, then it's I don't know. That's what I was thinking.
Yeah, I mean, that's why the data shows that if you greater than 10 minutes of clamp time from that standpoint, they start to see complication rate starts to kind of a logarithmic start to shoot up. And so, less than 10 minutes is kind of really what you shoot for. I mean, usually it's about anywhere from 6 to 8 minutes of kind of clamp time to, getting this, doing your pre-dilation, putting a stent in there and then, running an IVUS up, intravascular ultrasound to kind of look to see, hey, how's the stent sitting? Is there good luminal gain? The angiogram does a good job of showing you, kind of what it looks like, but you can't really see maybe an AP. So we used to take multiple angles of shots and things, which took more time. Now you can run an intravascular ultrasound up real quick and you can get, real quick feedback. You can make sure there's no plaque protruding through the stents, through the struts. Make sure it's got a good, distally, has good wall apposition. There's no evidence of dissection or anything distal. That's one of the most devastating things with this is you got to be real careful that you're not in a dissection. And so, evaluating that at the end is important. They had one in, I think, one of the hospitals towards Atlanta, the rep was telling me the other day, they deployed it into a dissection plane and, pretty bad scenario at that point. And somebody you're already, worried about getting to the end of the lesion. So, but, I think if you stay under that, then, we haven't had a problem from a cerebral monitoring standpoint. Been doing it for 6-7 years now, and luckily our number is still 0. So we want to keep it there. But you'll be surprised with you can tell when you put the flow reversal in. Some people have very brisk back bleeding. Some people have slower. The blood coming back through the tubing. You can actively see that once you clamp the common and you flush. You got to ensure that you got backflow. And you can tell some of them it goes very quickly and their other vessels are open. Some it's very slow and very sluggish, and they still tolerate it okay. I mean, contralateral occlusions we do all the time and do a TCAR on them, and you're pretty surprised. This good Lord gave you 4 vessels going to the brain for a reason, kind of making up for it.
If you're approaching that 10-minute mark, are there any bailout procedures?
I mean, bailout is, always open surgery. So, you just got to be real careful, making sure wires and catheters are in the right spot and, taking your picture and just kind of ensuring. One thing I always kind of harp on everybody in there is always having that wire spinning. So if you're kind of, manipulating it, moving it, I mean, it's not a pushing, it's kind of a spin and guide. Just pushing is the problem. Get you in a dissection flap real quick. But if the tip of that wire is moving and it's constantly spinning, then you're not in it. You also want to see it make the turn up at the kind of base of the skull. It'll always make kind of almost a loop there. And you want to see that, then you know that you're in it, you're in the right spot, you're in the right vessel. And then, then you kind of go from there and work, relatively quickly. So usually you kind of pre-dilate. Most people, they won't necessarily post-dilate, but, you can for sure, especially if you see a little debris kind of poking through the struts on IVUS, you can just balloon that and dilate it. Or some people will reline it with another stent, with the thought being like a chain link fence. If you can kind of get those pieces of this kind of a gap, then you put another gap over it, and the chances of it being perfectly aligned are pretty low. So you can kind of push that to the side and kind of pin it. So that's the goal. But yeah, bailout, just move quick.
Thank you so much.